72-year-old man, like, you think there is risk. Something could be wrong. You could be afraid that he might have had a seizure too. Even though things are less likely, you have to think about the benefit, right? Oftentimes, bringing someone to the hospital is not the correct answer, right? You're not magically going to have, an answer at the end of a hospitalization. And if you could have had the same result by just following up in the clinic, then did you really need to bring them to the hospital anyway? Hospitals are dangerous places, right? The amount of blood draws that you do, the lines, the nosocomial, the hospital-acquired infections. I mean, it is not a perfect place to put a 72-year-old man in. Hospital-acquired delirium is another one, right? So anytime you bring someone to the hospital, you have to weigh the pros and cons.
A 72-year-old man comes to the emergency department after a brief episode of loss of consciousness. So they seemed like they passed out, but it was only for a short period of time, which is actually pretty important. The patient was waiting in line to purchase a movie ticket when he felt warmth and nausea and started sweating. Okay, details about what happened. He then collapsed to the ground and was unconscious for 1 to 2 minutes, so a pretty short period of time. According to his wife, who witnessed the episode, that's always important. If someone witnessed the episode, ask them for what happened, because they can usually give you more details about what happened. If you imagine you passed out, you're not going to know what happened, but your partner or a passerby, a bystander, they can probably tell. He had 2 or 3 jerky movements of his arms. That's something to note too. No tongue biting or urinary incontinence. He didn't wet himself because of the fall and the loss of consciousness. The patient was briefly hospitalized after a similar episode about a year ago, and they got some tests. They got blood tests. They got an electrocardiogram, which looks at the rhythm of the heart, the electricity, like we saw earlier for the previous patient. And they did telemetry, which is where they hook you up to pads, little stickers, onto a heart monitor. And that's the thing that goes beeping in like the TV shows or the medical dramas and everything, right? Those are all normal at the time. So his testing, again, I guess whenever I have a question, things are normal. I don't know if it's just me, but patients seem to be doing okay then. Here's his past medical history that you ask. He's got high blood pressure. He's got high cholesterol. He's got type 2 diabetes, but it's diet controlled. So really, he doesn't need any medicine for it. He's doing pretty good. And he has something called diverticulosis, which is an outpouching of your bowels because of a few things. Like, for example, if you're constipated, your bowels, which are usually pretty malleable, can get punched out into like a hole, and that can cause problems. So from this, just from looking at the history, the things that stand out to me a lot is that it's a very short period of time, right? You think about people who pass out for one reason or another, right? If they're having something medically concerning that will be a reason to rush them to the hospital, a seizure, for example, that's something to think about, right? Those jerking movements, that could be a sign of a seizure, right? It could or it couldn't. You could also have had what we call syncope, which is what happens when the blood flow to the brain gets shut down for a quick second or two, right? You might feel this if you have a fear of blood and someone pokes you to get a blood draw, and you pass out, right? Some people say, I can't stand blood draws because I pass out when that happens. Other times it could be because of a heart problem, right? Your heart's beating wrong, and then it's not pumping blood forward. Could be another thing. Or maybe they had a stroke or something with their brain that turned the blood off, right? So there's a lot of high value real estate in some of these areas. Something definitely take seriously. I use that phrase for patients. I say that all the time, and I think patients like it, but I don't know. That's when they say like chest pain, I'm like, that's a high value real estate. You got your heart and your lungs in there. Pretty important.
I mean, it's true. It's true. So what's low value real estate? Like they have like middle finger pain or something?
Yeah, I saw one of those people today. Briefly went over the differential there, right? It could definitely be something neuro-related, brain or nerve-related, or it could be something heart, or it could be something not any of those kind of, right? It could be an episode of syncope from something else that we can go into. So when we think about those differential diagnoses, right, we got to think about what are we looking for on exam that could point us there. Right, that's always kind of what doctors try to do after we ask you a ton of questions. It's not just because we want to know if you have a dog or not, because we're trying to figure out what could shape what our suspicions are, right? They try to show it on the TV shows. I don't know if they do a great job because they know the answer. We don't know the answer, right? Not necessarily, although I guess we might know the answer to this one. So we take a look, for example, at their vital signs. Is their blood pressure down? Is that why they're passing out? Because they're not getting blood flow to the brain because their blood pressure is nothing. Turns out his blood pressure is pretty good, right? Heart rate. Is their heart going really fast and not beating super well? No, it's doing pretty good here. And then orthostatic changes. That's a pretty interesting term, but what it means is, does your blood pressure drop if we try to move your position from like a lying down position to a sitting position or a sitting to a standing. And the reason why that's important is because if you're dehydrated or if you got something wrong with your autonomic nervous system that's controlling that, then your blood pressure could tank when you try to sit or stand up, right? I know someone who has that happen to them. And if that happens, you can pass out because the blood's not going up to your brain like it should. In this case, this person's also doing fine. In fact, they tell you, the person's alert and interactive. They're talking to you. I know some of my patients sometimes in clinic, they're not really that interactive. I don't know if it's my fault or if it's because that's just their concerns. But this person is talking, is answering questions, seems to be participating with you. Sounds like a person who's doing pretty okay right now, right?
A lot of people in the YouTube chat are really split on this too, right? I mean, it's D, it's E, it's B, it's C. I think everybody's at least said something except A. I don't think anyone said A so far yet. Yeah, I mean, I agree. There's a lot of benign sounding stuff going on. Yeah. So, I mean, yeah, a lot of people seem like they're pretty split. I mean, this guy clearly seems like there's something wrong, right? Potentially he collapsed, had some jerking movements. You know, are you worried about a seizure? Are you worried about him passing out? Are you worried about his heart? Long story short, I think that I'm going to actually go ahead and pick B. Okay, yeah. My pointer was on B also.
And the reason why I'm picking B is for a few reasons, right? So what do I think this diagnosis is, just by kind of after my long-winded explanations of things? I think it's something called vasovagal syncope. Syncope is, like we said earlier, issues with blood flow to the brain. And sometimes that can happen in response to very intense emotional issues, stimulation, or events, right? Like we talked about drawing blood. Vasovagal syncope itself is fairly harmless. It's a sign of a reaction with the vagal nerve. That's where the name comes from, which is like a giant nerve inside of our body. And usually the recovery is swift and there's no underlying signs of injury, like nerve injury, seizures, or anything like that. What are some clues that we have to this, right? They did all this testing before. The testing was fine. He already had an echocardiogram. He had blood tests. He had everything done. Those were normal. Blood pressure's fine. Orthostatics are also normal. That's another possible cause. And then you might say, what about the jerky motions? Isn't that a potential seizure? Well, the main things we think that are unlikely to be a seizure is how short it was, right? You can have jerky motions with syncope that are not similar to like a generalized tonic-clonic seizure or even like a myoclonic seizure, right? And the fact that he recovered so quickly without any tongue biting, without any wetting himself, which are usually signs that the nerves are disinhibited, right? They're no longer being controlled because the brain's fried from a seizure. And he also didn't have any episodes of feeling confused afterwards, which is usually a sign we call a postictal state associated with a seizure. So because of that, we think less likely to be a serious problem. So fairly reassuring. Instead of doing all these tests that are going to be unnecessary, just send him home and have his primary care doctor see him, make sure he's doing okay.
So I also think reassure and advise primary care provider follow-up. I know sometimes like this answer doesn't always seem right? Like, 72-year-old man, like you think there is risk, something could be wrong. You could be afraid that he might have had a seizure too. Even though things are less likely, you have to think about the benefit, right? Oftentimes, bringing someone to the hospital is not the correct answer, right? You're not magically going to have, an answer at the end of a hospitalization. And if you could have had the same result by just following up in the clinic, then did you really need to bring them to the hospital anyway? Hospitals are dangerous places, right? The amount of blood draws that you do, the lines, the nosocomial, the hospital-acquired infections. I mean, it is not a perfect place to put a 72-year-old man in. Hospital-acquired delirium is another one, right? So anytime you bring someone to the hospital, you have to weigh the pros and cons. If they have an acute issue that absolutely needs hospitalization, something that legitimately requires inpatient management, then yes, you need to bring them to the hospital. But if it's just for what is potentially a vasovagal syncope, something that can be worked up in the office and something that's immediately not causing any danger to them, you have to weigh the risks and benefits of actually bringing them in. Then you're also thinking about cost, you're thinking about use of resources, and you also want to, think about how much of the actual presentation here is reassuring. So the unconscious for 1 to 2 minutes, 2 to 3 jerkings of the arms, and no tongue biting or urinary incontinence makes me think this is less of a seizure. And if you notice, I highlighted this, when he read it, waiting in line to purchase a movie ticket, and he felt warmth and nausea too. Like, this aura actually is what really kind of screams vasovagal for me. I think somebody said that maybe he was just locking his knees, right? If you were in like high school choir, or if you've ever been at like a music festival or a concert or something, right? The big thing they tell you is like, don't lock your knees, right? Make sure that you're constantly moving your legs, making sure the blood is circulating. Because, if you are in that prolonged standing position, your body at 72, might not adjust to that in time, and you can eventually pass out like that. There are a lot of things here that are reassuring, like a similar episode 1 year ago, which could have also been vasovagal. He already had the workup and the blood test, ECG, and telemetry, which is the long-term ECG monitoring. All of those things were normal too. So if you're able to connect those dots and realize that a repeat admission to discover the exact same negative results and would just be a waste of time for the patient, a waste of money for the patient, and a waste of resources for the patient that could be spent on somebody who's more sick instead, I'm going to agree, and I'm going to say B here. Yay! Yeah, so this was a tough one. Yeah. I mean, 37% got it right, which means 63% of people got it wrong. And a lot of people also said, tilt table testing, right? Because, what if it is, something that could be in the autonomic nervous system? It's not unclear in this case if this guy doesn't have a history, or that we're still working up neurocardiogenic syncope, and especially with the fact that he didn't have orthostatic changes, meaning that from lying down to sitting to standing, his blood pressure and his heart rate did not change significantly. A 65-year-old man comes to the emergency department because of worsening generalized itching for 7 days. He's experienced abdominal discomfort, bloating, and decreased appetite for several weeks. He's lost about 10 to 12 pounds during this time, which he attributes to excessive stress at work, or, probably because he's not eating enough. He denies nausea, vomiting, diarrhea, easy bleeding, or bruising. All right. I mean, I'm thinking, gallbladder, some biliary symptoms, pruritic rashes. He's not, eating as much, which is leading to him having these weight losses, but it's not like a lower GI symptom where he's just actively pooping out so much stool or free water, that he's having these metabolic changes. So yeah, 10 to 12 pounds in 7 days. Like that's pretty bad, right? His temperature is 98.4, so not really looking like an infection. Blood pressure is 123/70, and pulse is 78 per minute and regular. So his body is compensating, and he's, doing pretty well medically. He is clinically stable. On examination, he has icteric conjunctivae and skin. All right, so he's jaundiced. He's got yellowing of the eyes and his skin, and he's got bilateral diffuse stretch marks, and there's mild tenderness on palpation of his right upper abdominal quadrant. So we're looking at his liver here, and that is slightly tender, or the gallbladder, and it's slightly tender. Tip of the spleen is not palpable, meaning that he doesn't have any splenomegaly. So we're looking at his blood count. CBC looks fine. Platelets look fine. Leukocytes, it looks fine. He does have some lymphocytosis going on. White blood cells are normal. His albumin's fine. His bili, T-bili, and D-bili are definitely elevated here. Alk-Phos is also elevated. And do we have a GGT? We don't, but I'm pretty sure it's coming from the gallbladder here. And he's got transaminitis as well. All right. So definitely pointing towards a gallbladder, liver, pancreas, that sort of area on the GI tract. Abdominal ultrasound reveals an enlarged liver with dilated intrahepatic bile ducts. Okay, so we've got some backup going on. CT scan of the abdomen reveals an ill-defined 3.5 centimeter pancreatic mass. Oh no. And several low attenuating foci in the liver consistent with metastases. Okay, so this pretty much spiraled to pancreatic cancer pretty quickly. Oh wow. So which of the following is the best next next step in managing this patient. This is a good thing, following up on the thing that I just said, right? So he has a pancreatic mass and he's got mets to the liver, right? So when you're thinking about anatomical relationships, he also has dilated intrahepatic bile ducts, which means that his metastases, or the actual mass itself, is pushing on this functional tissue in the liver and obstructing his bile ducts, leading to that kind of bile lake pathology that I was talking about up here, leading to his jaundice and everything. So he does have pruritic rashing. He does have extreme weight loss from this pancreatic cancer. But actually, in order to get this guy feeling better, I need to make sure that those bile ducts are actually draining and making sure that he's actually able to relieve this obstruction and actually able to start, eating food again without feeling like crap. Like, yes, he has pancreatic cancer and there is a lot going on here. But if I was, this man is in the emergency department. If I was the hospitalist admitting him, like, that is the first thing I am calling the GI doctor for. I'm not trying to give, well, actually, do I want to give him pain meds too? Like, he's not in pain, right? He's just itching. Okay. Right.
Yeah, he's itching.
So yeah, he's pruritic, itching, and he's jaundiced, right? So I want to make sure I can alleviate his symptoms first, and then we can get on board the oncologists, the surgeons, give him, ursodiol, whatever he needs, potentially chemo. So yeah. Do you agree with me?
Yeah, I agree. I think the question writers are trying to catch you maybe with between A and C, right? Because you could do a biliary decompression surgery to relieve the pressure on his biliary ducts, or you could do a stent. Which one is better?
I've never actually had a patient undergo biliary decompression. Like, they've actually, like, GI has always, like, put in one of those, like, stents, like bare metal stents or whatever.
Yeah.
Actually, what does biliary decompression actually entail here? Because,
like, debulking or something,
right? But, like, he doesn't really need debulking because it's the tumor burden that's, like, compressing it from the outside, right? So
right.
it's not like it would help. Like, you need to put in a stent so that the actual bile duct gets. He's overthinking, right? Yeah, he's it. Okay, good.
There we go.
Damn, you got me there. All right, yeah, here we go. Surgical biliary decompression, like a cholecystojejunostomy. Okay, so connecting the gallbladder to the jejunum, or the choledocho. So connecting the CBD to the jejunum is reserved for patients who cannot go under. Yeah. So you would do the decompression by, like, creating a connection to allow the biliary system to drain directly into the small intestine instead of stenting the existing roads, basically. And you would only do that if they can't undergo stenting because of however the anatomy is presenting itself. Yeah, so pancreatic cancer, scary disease, 7 days, right? Like, all of this really came on in the past 7 days. He started losing a lot of weight in the past 7 days. Like, you'll start to see this constellation of symptoms quite often, and it'll creep up on them, and suddenly it'll get them to the point where they go into the ER.
So a 46-year-old woman is seen in the emergency department for severe headache, accompanied by nausea since she awoke this morning. She was diagnosed with hypertension or high blood pressure 7 years ago and took medicines for only 2 years. And then the patient stopped the medicines and did not follow up with doctors because she felt fine. It's actually something that I see a lot. She has a history of remote but not active intravenous drug use. And she's a current smoker with a 20-pack year history. So both important details about what her habits are. Again, kind of similar to what Saiken's talked about before, we don't judge, or rather, we're not supposed to judge. I know doctors unfortunately do, because we're human. But the goal of asking these questions is not to say, haha, you do drugs, it's bad, you're a bad person, but to kind of get a sense of how can this factor into your health, especially if you come to the emergency room feeling awful, right? Feeling a severe headache, feeling really nauseous. So just by looking at this, things I'm thinking about, right? She's relatively young. She has some history of high blood pressure and is not taking any medication. So I'm thinking, is she having really, really high blood pressure, what we call hypertensive emergency, which can sometimes happen? Or is it something else? Is it related to her history of remote drug use that could have turned into something that was brewing for many years? Let's go take a look at what the vital signs and everything show. So they do her vital signs pretty quick. She has a slightly elevated temperature, though not technically a real fever. The cutoff we usually say in Fahrenheit is 100.4 or 38 degrees Celsius. So not really a real fever, but a little high. Blood pressure, as I was maybe thinking about earlier, is quite high, 176/105, which is pretty high.
But it's not exactly hypertensive emergency, though.
Exactly.
Technically,
it's high.
180 is where you're worried about.
Especially when accompanied by how she's feeling, right? In the clinical context of things, something is up. And these blood pressure numbers don't look really reassuring for it, right? Pulse is a little high, 100's like borderline as well. So definitely some concerning numbers here. She appears lethargic. She feels less reactive when you talk to her, maybe a little bit sleepy, maybe a little bit not entirely with you when you talk to her. Mild neck stiffness, that's usually a concerning sign. And then you take a listen to her heart, you hear a murmur, apical 2 out of 6 holosystolic murmur, which is a way to describe kind of a murmur that happens when the heart squeezes, and it's loudest at the very bottom, which is very confusingly the apex of the heart, just because that's how people decide to name things. Lungs sound clear, which will be important later when we talk about hypertensive emergency. Deep abdominal palpation shows bilateral firm flank masses. So that's not supposed to be there. Why are there masses inside?
So I'm gonna make that one a different color because this changes this changes the
everything.
game.
There is no peripheral edema or skin rash, and there's no focal muscle weakness or cranial nerve deficit. So really nothing else on the skin, nothing else on the nerves. We get an electrocardiogram and ECG shows sinus tachycardia, left ventricular hypertrophy. So the left ventricle is bigger than it's supposed to be, which can be signs of like chronic high blood pressure that's not very well controlled. And then you also see some secondary ST segment and T wave changes, which is a little bit technical, but in this situation, I think the context shows it's probably also related to chronic high blood pressure changes, and maybe even a sign that her heart can't keep up if her blood pressure is too high, what we call demand ischemia. All right, blood tests. We get some blood tests here. All right, let's see. Hematocrit 40%, platelets 140,000, leukocytes 6,100. All right, those look pretty normal, but the serum chemistry, creatinine's high at 2.2. Now, we don't know her baseline, but she said, or at least what we can tell, no past history of any kidney problems. So we can assume this is very different and abnormal from what it's supposed to be, right? For analysis, we get a urine test, and it looks like there's some protein there, and definitely abnormal white and red blood cells, and a lot of red blood cells too. Something that definitely is leaking through the kidneys, or something is damaged about the kidneys, which makes sense with the creatinine, which is a test that we look at to look for kidney function as a marker of kidney filtration.
Yeah, so even, I mean, honestly, even before we go to the answer choices, like, I know we were saying, like, you know, everything in the question stem is important. Every positive finding is important. You know, every negative finding is important. But the one that I highlighted in a different color, bilateral firm flank masses. So this is definitely pointing towards like a physical kidney issue. And, you know, this is just an abnormal finding, period, right? Like, you should not feel masses on the patient's flank at all. Before we're even interpreting any of these labs in this context, like, I'm already not really worried about like individual, like an acute kidney injury or like a specific, you know, kidney pathology like glomerulonephritis or like a nephrotic injury. Like, I'm kind of worried, like, what are these masses doing here? And I feel like, you know, you're right. We have like 60 questions in an hour and a half or something like that, right? Like, if you don't read it carefully and you just scroll past this, like, and you don't recognize that, oh, whoa, they had bilateral firm flank masses on the physical exam. Like, I've definitely done that before on the tests or like on, or on the board prep too. So like, definitely, like, you sometimes miss like very important information that changes the entire trajectory of the case.
All right, so I think, and this is what I'm putting down here. I think the headache, the high blood pressure, I think a few things are definitely related here from those bilateral masses, right? And if you think about what could be going on that can kind of come and go, really related to high blood pressure and someone who's really quite young. That's the other thing, right? Is that this person otherwise is quite young, and we don't really expect them to have really high blood pressure for not much reason, right?
Usually, I think that's diagnosed with it at 39, which still is pretty early. And then she was probably uncontrolled from 41 to 46.
You know, when I think about those masses, I think about uncontrolled high blood pressure in someone who's that young and potentially coming and going. I'm starting to think of whether or not this is something related to either like cysts in the kidneys, polycystic kidney disease, or is it related to adrenals or not? Now, this is bilateral, which is a little bit atypical for like a particular mass from the adrenals, although it could be adrenal hyperplasia. That could be it, though I think less likely. If you do test taking techniques here, brain metastasis probably not likely. I don't think it's cancer. Hypertensive encephalopathy, it could be that, though the blood pressure, like Saiken mentioned, is not what we consider to be in the range of hypertensive emergency, which is 180, usually systolic, the top number. But I think it's possible, but less likely. Non-communicating hydrocephalus, I think, is probably less likely related to her normal neurologic findings. Subarachnoid hemorrhage, if we think it's PKD, then it could be that. And then viral encephalitis, we think is less likely given the normal white count, and lack of fever, though it might hidden away if we don't do a lumbar puncture. But I think it's less likely that too. So really, I'm thinking either B or D here. I think if we have to choose one, I'd probably lean more towards D than B, but I think this can definitely be tricky.
I think, yeah, I'm also leaning more towards D, but, for an acute presentation, B could also be there, right? My concern is that she has had blood pressure problems for the past 7 years and has been uncontrolled for the past 5 years, and she's still smoking, right? And she's coming in hypertensive and lethargic. So even though, this could be an isolated episode of hypertensive encephalopathy, there are too many red flags in the history pointing at why she could be having a new stroke. And I think with, the firm flank masses being, polycystic kidney disease, that's going to be a very difficult blood pressure to control in your adult life. And the more time you spend at living in the 170s, 180s, your risk for stroke is just going to increase and increase from there. I think the most likely one is that she's having a new stroke here.
I think the other thing to think about too is when you think about the headache, this is like a med student flashcard thing, right? It's like a buzzword, what we call a thunderclap headache. It's really intense all at once. It's almost certainly because of a subarachnoid hemorrhage. Now, they don't say the words thunderclap on here, right? But they say really severe headache since she woke up this morning. Now, I guess we don't know what time of the day it is, but if she got rushed to the ER immediately after she felt this headache, it just started and it hit her hardest right away, then that would make me think D much more than B for sure.
Yeah, I'm good with D.
Let's do it.
Nice.
There
Yeah, so 24% of people said hypertensive encephalopathy. So that was definitely on the differential for a lot of third-year resident internal medicine doctors too. so you guys definitely were not wrong in that. But yeah, so polycystic kidney disease, the bilateral flank firmness, that probably was there too. So the cool thing about boards is that they will tell you, in the study materials, why the answer was wrong. So although this patient may be at risk for hypertensive encephalopathy, her low-grade fever and neck stiffness indicate subarachnoid hemorrhage. Low-grade fever in general is common with intracranial hemorrhage. Her blood pressure is also not severe enough to cause hypertensive encephalopathy, which is greater than 180 over 120 millimeters of mercury. So that one could be a technicality too, right? I wouldn't say you need to have over 180, but I think for the formal definition, they wouldn't give you something outside of that, on the exam.